Welcome to our podcast on navigating complexity, ethical dilemmas in end of life care. I'm Chi Ying.
I'm Rebecca.
We are final year students from the Law Faculty of University Malaya. Today, we delve into a topic that touches us all: the profound ethical decisions faced by healthcare providers, families, and society when managing end of life situations. Imagine this. You are in a hospital room surrounded by loved ones, facing a critical decision about the care of a family member nearing the end of life. Questions about quality of life, treatment options, and honoring their wishes weigh heavily on your mind. These scenarios are not uncommon and resonate deeply with many of us who have confronted the complexities of medical ethics and the emotional challenges of saying goodbye. In today's episode, we explore thought provoking scenarios and ethical dilemmas that have shaped how we approach end of life care. Let's explore together how we can try to maneuver through medical decision making that is ethical and tries to honor the wishes of patients and respect their autonomy while ensuring dignity and respect during some of most challenging moments of our lives. Together with us is Dr. Mark Tan. He currently works at the Faculty of Medicine, University Technology Mara as a lecturer in medical ethics and law. He has received his doctorate in bioethics from Loyola University Chicago and certification as a healthcare ethics consultant from the Healthcare Ethics Consultant Certification Commission in the United States. Dr. Mark chairs the Clinical Ethics Committee at Hospital Al Sultan Abdullah UITM and the Malaysian Medical Association Ethics Committee. He is also Vice President Medical of the Medical Legal Society of Malaysia and Deputy Chair of the Expert Panel of Clinical Ethics Malaysia. His area of interest focuses on clinical ethics, specifically in end-of-life ethics and making advanced decisions. Dr. Mark, as a clinical ethicist, can you please tell us what exactly is clinical ethics?
Hi, Jean. Hi, Rebecca. Thanks very much for having me on this show. Yeah, that's a really good question that I get asked often, right? So clinical ethics is rather new in Malaysia. It's actually a structured approach to ethical questions that arise in our daily clinical practice as healthcare professionals. And it provides a systematic way for us to identify and analyze the ethical questions or issue so that we can reach a reasonable conclusion and generate recommendations for action. And this is done in the context of a consultation service usually, which delivers this to help patients as well as the healthcare providers to reach these ethically justifiable solutions. Um, and this is important because ethical issues, as you mentioned, happen every day in daily clinical practice. And, it spans the whole spectrum of issues with consent, confidentiality, to more complex things like what we're talking about today, right? End of life and, access to healthcare, etc. And clinical ethics is often, the issues that come up are often of great importance to the lives of the interested parties, be they the patients or the doctors. And most of the time, by the time it comes to us in the clinical ethics service, it's often very complex and quite difficult to resolve. And, I think the cases that we'll discuss later on in this session will kind of give a flavor of what we encounter in clinical ethics.
All right, doctor. You mentioned about end-of-life care just now, so could you please tell us what is the exact meaning of the terminology end-of-life care in healthcare practice?
Um, wow, the exact terminology. Well, I guess what we can think about is, what it says, right? End of life care. So the question really is, when does the end of life begin, or when do we consider things to be at the end of life? And so end of life care is the care that we provide at that phase of our lives. And this usually is a kind of a spectrum And also depends on, how we kind of die. And if we look at it, there are actually many ways in which, we can die. Some of us have a very sudden death, right? You get a heart attack and you die almost immediately sometimes. Some of us get into say a road traffic accident and, die at the scene of the accident. But some of us run a more chronic, longer term kind of period. So things like dementia. So patients who are a bit more elderly are more prone. Dementia happens where they get a bit more forgetful, and then it involves behavioral problems and so on. And it's a whole spectrum, and it's progressive, and it never gets better, but it spans a long period of time. There are also some other conditions, like patients have chronic diseases like kidney failure, liver failure, heart failure, um, or it could be something like cancer. And so end of life care would start when we think that the patient is facing the final phase of their lives with these sorts of conditions, and may also include what you may have heard of as palliative care, right? Which usually provides palliation. Um, and also, there's another phrase that we use called the active phase of dying. And those are really like the last few hours or days where we can see that the patient is, what we call actively dying. I mean, they're going to die in the next couple of hours, and so there are also different types of care that we can provide in that kind of period. So all of this encompasses end of life care.
Thank you, Dr. Mark, for the explanation. I'd like to ask, how do the four ethical principles, which are autonomy, beneficence, non-maleficence, and justice, how do they actually relate to end-of-life care?
Great question. So again, I think the four principles are, I think, the most famous thing in ethics, right? First proposed by Beecham and Childress, but they're by no means the only four principles out there in terms of ethics. Now, sometimes in clinical ethics, we use something called a four-box method, where a framework has been drawn up to make sure that we don't miss things. And these four boxes are medical indications, patient preferences, quality of life, and contextual features. And each of these four boxes relate also to these four principles. So for example, when we're talking about making medical decisions, the patient's preferences, this would be related to respect for autonomy, for example, where we really want to try to empower the patient to make decisions as much as they can. We'd like to know what their preferences are. And if we know their preferences, we would want to try to respect them, right? So that comes into respect for autonomy. When we talk about proposing the kind of medical treatment or the options that the patient has, we look at maybe the first box, which is medical indications. So we would want to think about beneficence and non-maleficence, i.e., which kind treatment option, or for each of the treatment options, what are the benefits? How much harm will the patient have to incur, or what's the risk that the patient has to incur? Because obviously with every treatment, there are pros and cons, there are benefits and there are risks. And so we're trying to balance these things out when we talk to patients about the options that they have available. And again, the last one, for example, justice, we'll talk about it in the last box of clinical ethics, the four-box method, which is, contextual features, for example. When we talk about things like allocation of resources, and we know that, healthcare resources are finite, there are limitations. And so we really want to try to be fair, be just in how we kind of allocate these sorts of resources to patients at the end of life. The other thing about justice is also, I guess, the law. And so we would want to make sure that, um, you know, whatever treatment that we provide does not go against any laws, specifically looking at things like, euthanasia and suicide, and how they relate, for example, in Malaysia. And so that will kind of determine what we can and cannot offer as well. So that relates to justice, for example.
All right, doctor. What are some examples of ethical dilemmas commonly encountered at the end of life?
Right, Jing. That's a loaded question, and I'll try to kind of take you step by step and to look at, some of the more common ones, more complex situations. So, I mean, to start us off, some of the things that actually one of the most common ones are with regards to decision making or surrogate decision making. And this is important in the context of, obtaining consent for treatment. Many times, patients who are at the end of their life may not have the mental capacity to make decisions. And so, in the hospital setting, we'll ask, if the patient cannot make decision, then who is going to make the decision for the patient? Or who has the authority to make decisions for the patient, right? And once we've identified who or the surrogate, the question is also then, how should this surrogate or how should this person make decisions? Are there any ethical standards that they need to meet and so on? And what happens if this surrogate then makes a decision that we as doctors feel are not the best for the patient? How do we handle this? Right? So those are kind of consent issues. Then obviously, if we relate this to the options or the decisions that need to be made, there are things like deciding on whether we should continue or we should withdraw life-sustaining treatment, like, a patient you mentioned in ICU requiring a ventilator. So, do we continue? When do we withdraw? For patients who may be a bit more chronic, and in certain scenarios, we have to think about decisions about continuing to feed the patient or to stop it. So we talk about withholding nutrition and hydration, for example. Are there any contexts in which we can do this? And how much suffering will the patient incur with or without this, right? And then there are times when, whatever we do may not be beneficial to the patient anymore. And we talk about things like medically inappropriate treatment. Or in the past, we used to talk about futility. There are issues surrounding, whether the patient is brain dead, for example, at the end of life. So that's a kind of a different definition of death as to what we commonly know as cardiopulmonary death. So there are ethical issues there. We sometimes encounter patients who are in very intractable pain, and providing them with pain relief may also cause certain side effects. So there are issues which we use what we call the doctrine of double effect to kind of justify why we give very strong painkillers, which may mean that the patient becomes a bit more drowsy. The patient may also become unconscious, but at the expense of being relieved of pain. Again, issues such as, whether to CPR, not to CPR the patient. Issues with regards to how much do we tell the patient at the end of life, Do we tell them the truth that they are dying? Or, sometimes we get requests from family, don't tell my mother, don't tell my father that they are dying. So do we agree to collude with the family members, issues with communication, obviously. And these sorts of things would also then, if we look further down the line, think about things such as transplant. So if the patient is dying or the patient is the patient an organ donor? What about organ transplant? Um, is there any possibility of, donating the body for research purposes and so on? So there are ethical issues that we have to also, tease out there. And lastly, I guess, I think I mentioned just now earlier about things like euthanasia, and in some other countries, this is legal. And for example, in Australia, they recently legalized what they call voluntary assisted dying. So, those sorts of things are also, ethical dilemmas that we encounter at the end of life. So I hope I've given you like kind of examples of, the spectrum and the range of what we encounter.
Yes, it definitely helps us understanding it. Perhaps a hypothetical scenario would even better illustrate this ethical dilemma. So let's say Alex, a 35-year-old patient, remains in a coma following a failed suicide attempt. So medical experts agree that further treatment is unlikely to improve Alex's condition. But however, Alex's family insists on keeping him on life support due to their moral or religious beliefs. So the attending physician faces an ethical dilemma between respecting the family's wishes and the medical judgment that continuing life support may only prolong suffering. So in such event, what should the attending physician do? Can you dissect this dilemma for us?
No, that's a really interesting hypothetical scenario. And I think to that question, what should the attending physician do if the attending physician is facing an ethical dilemma as such? Is that if they are in a Malaysian setting where there are clinical ethics consultation services available, I think that's one of the things that this physician should do, which is to call for help, call for an ethics consult, engage with, everyone who's involved in the patient's care to try to tease out, all the facts, and to weigh it so that he or she can come to a decision. And if this does come to, for example, me in a clinical ethics service, so basically, if I get a referral of this case, then, this is how I would kind of think about it very, just very quickly. Um, so I guess, remember we talked about the 4 boxes. So we can go through that. And really the 4 boxes are really to help us not miss things out. So we're talking about things like medical indication in the first box. We're talking about what is this patient's condition? Okay, this patient is in a coma, right? Why? And that will give us some idea as well. So he had a failed suicide attempt. So the question is, why did he attempt suicide? Does he have any underlying psychiatric disorder? Was this something, or was it just something temporary, some temporary stress that he couldn't deal with, right? Or was it something more chronic, like, depression? Then we look at, what are the treatment that has been done so far. And when you say further treatment is unlikely to improve his condition, what are we talking about? What are the options that we are deliberating here, right? Is this about ventilation? Is this about giving the patient a little bit more time? Or does the patient have some infection and we're talking about those kind of antibiotics or whatever? And what is the patient's diagnosis actually now, right? This coma. So again, there's a whole spectrum, right? Of from things like a permanent vegetative state to a minimally conscious state. And all of these have different implications. Yeah. Then if we go on to the next box, we talk about patient preferences. So here, obviously, he's in a coma, so he can't tell us what he wants. He doesn't have the capacity. But maybe we want to find out, for example, what did he want when he did have capacity? Did he ever talk about, you know, being in such a condition, whether he wanted treatment, whether he didn't want treatment, that kind of thing, whether he wanted the life support, whether he wanted the nutrition and hydration. So we want to know his previous values, his previous preferences, if we can. And we do this by talking to maybe the family or the friends, right? Because as doctors, obviously, we may not have known Alex before this. We will want to find out also, for example, like what I said just now about surrogate decision making. So now he's in a coma, he's 35 years old. Is he married? Does he have a wife? Does he have children? Or are his parents, for example, the surrogate decision maker, right? So when we say family's wishes, who exactly, right? So we want to know that kind of thing and who can make decisions for him. Then we talk about, say, for example, the third box, which is the quality of life. So, in the scenario, I heard you mention things like prolonged suffering, right? Things like unlikely to improve condition. So the question really is, what is suffering for him? How much suffering do you expect? What's his kind of possibility of coming back to normal, for example, his what we call pre-morbid state, right? And if it's not possible, then, if we are able to take him off the ventilator, for example, how much more time will he spend in the hospital? Will he need a nursing home? And it flows into the next thing, which is the contextual features, right? So basically, if I want to discharge him, what's his quality of life? Where is he going to go? Is he going to a nursing home? Or does he have a nice house? Does his family have the capability to hire a few nurses around the clock? Or is it that everyone is, going out to work and he'll be left alone? So we talk about quality of life in order to be able to try to understand, right? Whether we should continue treatment or whether we should, withhold it or withdraw it. Then, of course, we also heard so in the last box, we talked about contextual features and, there were things that you mentioned, such as moral and religious beliefs. So we want to explore a little bit more with the family, right? To say, actually, what is your religion? First of all, and what are these religious beliefs, right? And for example, try to understand how perhaps withdrawing treatment would be inconsistent with those beliefs. We want to also look at how they made that decision about suffering, for example. And so there are a lot of, then of course, there are also other contextual features like, which hospital are we in? How much is the cost of treatment? If he's in ICU, how long more will he be there? Because obviously each ICU bed is very precious, and so on. So we would look at all of this. We would talk usually to all the doctors involved in his care. And presumably, there's the ICU doctor. There's also the psychiatrist, maybe because he attempted suicide. And then we look at, what are other problems that he has, right? So if you say that he's very bad and he is unlikely to improve his condition, he probably has some kidney problems, he probably has some lung problems. So there'll be also all these other doctors. There are also the support staff like the nurses, the physiotherapists, the occupational therapists, and so on. And he's quite young, he's 35, right? We'll talk to things like social welfare, in order to get a better idea before we can actually answer that question of, what should the physician do, or basically how should the healthcare providers or the team decide? Yeah.
All right, thank you for the thorough explanation, Doctor. In your work, Doctor, you did a lot with advanced decision making and advanced directives. Can you share with us what they actually are and why you think they're important? Perhaps you can also share about the potential benefits and drawbacks of advanced directives from both a user and systems perspective.
Yeah, sure. that's really pertinent. And, looking at, for example, this case that we just discussed, right? So we have a 35-year-old patient whom perhaps we may know literally nothing about, right? And because of his failed attempted suicide, he came to the emergency department, and that's the first time doctors are actually seeing him. So when we talk about advanced directives, it's part of this concept of making decisions in advance, or advanced decision making. And the whole idea is that we should encourage people to make decisions about their values, about the treatment that they would want or not want, at a time when they have the capacity to do so in a kind of recorded format, so that when a time comes when they are no longer capable of doing so, they're incapacitated, we know exactly what they would want, or we could decipher what they would want from the values that they have stated. Now, there are many ways in which this can be done, and various countries have used different tools in order to do this. So, for example, in America, they have this thing called the Physician Order for Life-Sustaining Treatment, or POLS form, right? Where they ask patients to tick options. So that's one way. And there is a law that makes it legally binding. In the UK, they have what we call a Mental Capacity Act, which allows for two things. One is a lasting power of attorney. I'm not sure if you all are familiar with that. So basically, you appoint someone to be your donee, and at a time when you're incapacitated, that person will decide on your behalf. It's called lasting, right? As opposed to just the normal power of attorney. It also allows in the UK for this thing called an advanced decision to refuse treatment, or an ADRT, right? So patients can state in advance what they would like to refuse if such and such situation happens, right? So it has to be quite specific. Nearer home, in Singapore, they have a Mental Capacity Act also, which allows for LPAs. But they also have another piece of law called the Advanced Medical Directive Act, which allows patients who have a terminal illness to make an advanced medical directive. So yeah, in Malaysia, currently, there are no specific laws related to this. But the good news is, I think somewhere in May this year, our Deputy Minister for Law and Reform publicly announced that we will be looking at enacting a Mental Capacity Act in Malaysia. And so I think work is currently in progress, as I understand it, to study this issue and to kind of draft out the kind of bill which will allow for sort of advanced directives or advanced decisions, whichever tool that they decide, to help. And this is really important because if we're just talking about the Malaysian perspective or the Malaysian context, we are heading towards an aging or aged society soon, right? More people are going to grow older, and we need to know when we want to empower them, right? Because society is also becoming more educated, and people will read and they will have preferences, and we want to encourage this autonomy. And to a certain extent, there is literature to show that, when patients do this, it helps the family. Because imagine if you were suddenly called to the hospital saying that your loved one was very ill, and then you have to make a decision. And what will you decide? How will you decide? There's a lot of distress and sometimes regret, right? Whether I made the right decision or not. But if we know exactly what our loved one wants, then it makes the decision easier, and it can alleviate this sort of feelings. So yeah, so that's why I decided to, research this and write on this for my master's. And actually, quite recently, about a month ago, there was an article that was published in the Asian Bioethics Review on issues about, making decisions and how we can look at surrogates in preparation for this Mental Capacity Act in Malaysia. Yeah, and I could provide you with the link if you wanted.
I believe this is very good news to all Malaysians as well. So, coming back to this scenario, there is another ethical dilemma that we would like to explore, which is fertile treatment. Could doctor please explain what it is, and is it ethical to continue interventions that are deemed fertile for patients?
Okay, cool. Yeah, no, that's a really interesting question and a very complex concept. I think I did mention it just now earlier, once or twice. Now, basically, the idea of futility comes from Greek mythology, lah, right? And basically, what it means is that no matter what you do, you will not succeed. So, in terms of, for example, medical futility, it's a very complex concept. But the idea is that no matter what you do, you will not achieve the outcome. So, of course, the question is, what is the outcome, right? So, for some people, the outcome is life or death, right? I don't mind as long as I'm alive, my heart is beating. But for some people, the outcome is really quality of life. I don't want to live unless I can be independent. So, first of all, you need to have a goal. What is that goal? And then the question is, can you achieve that goal? Or is no matter what you're going to do, not be able to achieve that goal? To add to the level of complexity, when we talk about futility, some people have even classified it into, categories such as physiological futility. So we look at things like, can we restore the heart back to this kind of function that we want, right? So physiologically, then we have quantity or quality. So at the end of the day, and why it's such an important concept is because ethically speaking, if something is futile, then it has been understood that the doctor does not have a duty to provide that. And legally, neither does the patient have the right to demand for that if it's futile. But yes, it's fraught with controversy. And I think the other thing is, how do we decide as medical professionals? Because usually when it comes to a situation as such, the patient will be cared for by a few doctors from different fields. So do we need all the doctors involved to agree? So does it have to be a unanimous decision that is futile? Does it have to be a majority decision? Or just one doctor says it's futile and that's it? You know? So place people elsewhere in the world have kind of moved away from talking about futility to talking about what is medically appropriate and what is medically inappropriate treatment. Because we find that kind of language a little bit more helpful in understanding. I think there was a second part to it, which was, is it ethical to continue the intervention? So yeah, so the whole idea is that that if it's futile, and no matter what you do, you will never achieve that goal, then as a doctor, professionally, you will not have that ethical duty to provide that treatment. Or you can ethically justify not providing the treatment.
All right, thank you, Doctor. I think the audience now are clearer with the concept of fertile treatment and also what is considered medically appropriate or inappropriate treatment. All right, so before we wrap up this podcast, we would like to know that in the context of Malaysian healthcare, do patients have the right to refuse life-saving treatment? And how will this align with the Malaysian Medical Council's guidelines?
Right. Okay, that's a really good question. And I will say that, first of all, we're talking about the Malaysian Medical Council guideline on consent for treatment of patients by registered medical practitioners. The latest edition is I think a 2016 or 17 revision. There is currently work in progress to update this guideline. But as it stands, we'll have to use the current version that's out there, lah, right? Now, in the current version, there is a section about the right to refuse treatment. Again, coming back to this principle of respect for autonomy, we're talking about refusing of treatment by patients who have the capacity to make decisions, right? So we're not talking about patients who don't have the capacity or are technically incompetent or don't have the competence to do so. So if a patient has been proven to have the capacity and the patient understands the consequences of not having the treatment, which may include, for example, death or permanent disability, and the patient voluntarily refuses this, then the guideline says that, you need to respect the patient's wishes. And so, yes, and this is kind of quite standard in most ethical guidelines, not just in Malaysia, but elsewhere in the world, that, patients can refuse treatment, but the key is they must have capacity and they must understand the consequences of their decisions.
Okay, so thank you so much, Dr. Mark, for joining us today and sharing your invaluable insights on end-of-life care. And your expertise and compassion have shed light on such an important and sensitive topic. And we truly appreciate the time and effort you have taken to be with us. So once again, thank you for being here and contributing to this very interesting and important conversation.
Not at
Thank
all.
you.
Thank you for that opportunity.